Hello, everybody. Welcome to our Human Rights and Psychology webinar series. This is our fifth webinar this year and the 11th altogether. We started last year and we try to keep a pace of once in 2 months to have a webinar. Today's topic is human rights and mental health. We usually try to connect our topics with some important days set by United Nations. And this is connected to the World Mental Health Day, which was on October the 10th. Today, we have three speakers, Helen Verdeli, Sandra Willis, and Stephen Marks. Our moderator will be Alison Santos, and the hosts, as usually, are Mary Bullock, and my name is Marlena Plasic. Let me introduce you with the organizations that are the hosts of the whole series. It is the Global Network of Psychologists for Human Rights, and it is the International Council of Psychologists. You can find more information about both organizations on the websites that are here. And let me remind you that International Council of Psychologists is organizing an annual meeting, which will take place on December the 2nd this year. And the topic is human rights, dignity, and justice, empowerment for all. So you can find more information and join the event. You can find both organizations are dedicated to promoting human rights in psychology and psychology and human rights. So you can see what is offered, you can subscribe, which is for free, and you can find information, especially about education, connecting human rights and psychology. Let me give you some information about today's technical details for the webinar. You are able to ask questions to our guests in two ways. You can either write them in the chat box or in Q&A function. Then we deliver also certificates of attendance. We do that automatically, not today, but in few days, to everybody who registered and who stays at least 40 minutes during the webinar. If you register, but you watch the webinar from a different address, please send us an email on the address that is written here, so you can receive your certificate. Also, if you need, we have turned on the closed caption functions, so you can see them if you look carefully on the website here on Zoom. And now we turn to Alison. Alison, please introduce our speakers for today's webinar.
Hello, everyone. Good morning, good afternoon, good evening, wherever part of the world you were in. We are very glad that today we have three great guests. I'm very honored to be moderating this webinar today. Well, I'm going to introduce you, the three of them. We have with us Sandra Willis. She's a psychologist with 30 years of experience in academic, government, and non-government organizations as the Director of Policy and Advocacy in the Global Mental Health Lab in Teachers College, Columbia University. She advises on adopting innovative research for evidence-based, inclusive mental health advocacy and policy in the humanitarian development nexus. Here is also with us Dr. Helen Verdeli. She is Associate Professor of Clinical Psychology at Teachers College, Columbia University, and founder and director of the Global Mental Health Lab. Dr. Verdeli has played a key role in landmark clinical trials on psychotherapy delivered by specialists and laypersons around the globe. She is a member of the Scientific Advisory Council of the American Foundation for Suicide Prevention and the Scientific Advisory Board of Depression and Bipolar Support Alliance. And also here with us, Dr. Stephen Marks. He's the Dean of the Jindal School of Public Health and Human Development at OP Jindal Global University, and Francois Xavier Bagnot Professor of Health and Human Rights Emeritus, Harvard University. with degrees in law and international relations from Stanford and several universities in France. He has worked for the United States Senate in Washington, D.C., the International Institute of Human Rights in Strasbourg, France, and UNESCO in Paris, France, for the Ford Foundation in New York, and the UN peacekeeping operations in Cambodia and Western Sahara. Well, now I'm glad to leave the floor for Dr. Stephen Marks.
Thank you very much, Ellison. I am very pleased to be part of this event and to share with you some thoughts that build upon a collaboration that I've had with the other two speakers. As a preliminary matter, I would like to mention that this collaboration has been one of the rare occasions when people from the psychology community and people from the human rights community who can give lip service to the intersection between the two rarely collaborate to get into the weeds, to see what's really going on. What do we really think in our approaches to addressing the issues involved here? And that's my first preliminary observation. My second preliminary observation is that we cannot address the issue of psychology and human rights without having foremost in our minds the tragic situation that is prevailing in conflict situations around the world. Of course, it's not just in Gaza, but also in the other conflict situations in Ukraine and Yemen and so many other places where the violence that is the result of political causes has caused enormous harms to the mental health of the people, both military and civilian victims. And this is a purely random selection of news items available today on the mental health toll of the conflict in Palestine, including a variety of journals that you can see on the screen. Obviously, that's a somber way to begin this. We are hopeful that this collaboration, building upon the strengths of the fields of psychology and psychiatry on the one hand, and of human rights promotion and protection on the other, can make progress, including in this conflict situation. Let me share with you as a preliminary thought the emergence of mental health in the context of human rights. Now, we all know that the Constitution of the World Health Organization, in a rather dramatic departure from previous approaches to health, clearly stated that health is a state of complete physical, mental, and social well-being, and mentioned that that is also a human right. However, when the human rights framework was initially created through the Universal Declaration of Human Rights in 1948, there was a reference to disability, but no mention of mental health at all. And the reference to health was in the context of an adequate standard of living for health and well-being. So it was not at the forefront of the emergence of the normative framework for human rights. In 1966, the Universal Declaration of Human Rights was transformed into legally binding treaty norms. And in the International Covenant on Economic, Social, and Cultural Rights, the right to health clearly stated that it relates to realizing the highest attainable standard of physical and mental health. There was some attention to mental health in the United Nations and to rights approach to that when in 1971, the General Assembly of the United Nations adopted a declaration on the rights of mentally retarded persons. You can immediately ascertain from the choice of language there that this was a period when mental health was addressed in that rather derogatory fashion as retardation. The Convention on the Rights of the Child addressed mental health in several provisions as part of the rights of the child in 1989. But the field emerged in the United Nations normative framework primarily in 1991 with the emergence of the principles for the protection of persons with mental illness and for the improvement of mental health care, the so-called MI principles. And then the UN standards for the equalization of opportunities of persons with disabilities dealt more generally with disabilities until the breakthrough of the moment when persons with disabilities played a significant role in the UN's elaboration of and a final adoption in 2006 of the CRPD, the Convention on the Rights of Persons with Disabilities. Now, the point that I want to make before getting into the intersection of the concerns of mental health and mental health professionals with those of human rights is to point out the fact that this approach, which was not at all common a couple of decades ago, is widely shared in the major frameworks within which reflections on improving mental health are advancing. The Lancet Commission on Global Mental Health and Sustainable Development recommended a rights-based framework for mental health, including mental health as a universal human rights, and of course was specifically alluding to the United Nations Convention on the Rights of Persons with Disabilities. So it is front and center in something as significant as the Lancet Commission. And this is reflected in other publications, such as this one that you can see on the screen, that specifically states that redressing serious human rights abuses experienced by people with mental disorders offers a unique opportunity to serve a high moral imperative and advance sustainable development. So the link between sustainable development, human rights, mental health has been emerging in the professional community. World Health Organization has, as I'm sure everybody attending this event is acutely aware, has updated recently its mental health action plan and now has a comprehensive mental health action plan for 2013 to 2030. But what I want to draw attention to is that the targets are quite explicitly relating to our concerns. And by 2030, the intention is to have 80% of the countries have their policies focusing on mental health in line with international and regional human rights standards, and to update their law for mental health in line with these same standards. So there is an awareness to say there is on this side a human rights framework, there's on this side experience with addressing mental health issues. It is now official policy of the World Health Organization to say all countries are expected to engage as targets in this comprehensive mental health action plan with integrating the two. And the most relevant provision and most quotable provision is, of course, that a human rights perspective is essential to responding to the global burden of mental health. That's not the only provision in the World Health Organization relating to mental health that addresses human rights. Obviously, the Quality Rights Framework, which is a training program that those of you working in the field of mental health and who wish to say, I'm ready, willing, and able to engage my staff and my team in understanding this better, you have a tool available for you in this mental health, disability, and human rights toolkit provided by the World Health Organization that seeks to promote human rights of people with psychosocial, intellectual, and cognitive disabilities. And as defined by WHO, the Quality Rights aims to change the mindset and practices in a sustainable way and empower all stakeholders to promote rights and recovery in order to improve the lives of people with these disabilities everywhere. It's also consistent with the evolution of the Sustainable Development Goals that allude specifically under SDG 3 to a target of promoting mental health and well-being with indicators relating to measuring severe mental disorders as part of the measuring of progress with respect to sustainable development. Now, that's sort of to say the framework that in the professional community, as evidenced by the Lancet Commission and by the World Health Organization, the integration of a human rights approach to mental health has emerged as one of the important features of recent developments. But let's come back now to the normative framework from the human rights point of view. The Convention on the Rights of Persons with Disabilities covers all disabilities, but with an explicit reference in the purposes to persons with disabilities include those who have long-term physical, mental, intellectually, or sensory impairment. And it refers to the integrity of the person as including respect for physical and mental integrity on an equal basis. This convention has been ratified by 188 countries. It is one of the major achievements of the human rights field for two reasons. One, widely devised, ratified, and two, it has been conceived and drafted with the full participation of persons with disabilities. Now, that provides a legal framework for a human rights-based approach to mental health. The Human Rights Council is the body within the United Nations that has responsibility for addressing human rights issues. And over its history, it has little by little allowed the approach to integrating human rights into mental health to emerge. This resolution, as you can see, of 2017, calls upon states to take active steps to fully integrate a human rights perspective in mental health, to adopt, implement, update, strengthen, or monitor laws, policies, and practices with this in mind. This is extremely important because it means that from the human rights point of view, we do have a clear commitment in this regard. The High Commissioner for Human Rights, which is the Secretariat of the United Nations that deals with human rights issues, convened a consultation on human rights and mental health in 2018, following up on that resolution that I just quoted, to identify strategies to promote human rights and mental health. And it was a rather major event for those of us who are working in the field of mental health and human rights, in which this consultation, which is not a treaty body, but is a consultation of stakeholders that called upon states to ensure that mental health care and services are based on the free, informed consent of the individual concerned, and that legal provisions and policies permitting the use of coerced and forced interventions, including involuntary hospitalization, institutionalization, use of restraints, psychosurgery, forced medicalization, and other forced measures aimed at correcting or fixing an actual perceived impairment, are repealed. So you can see from the language used here that clearly these human rights stakeholders were drawing upon the experience of professionals in the field of psychology and psychosurgery. The Human Rights Council also received the input from the Special Rapporteur on the Right to Health, which is a procedure in which an independent expert draws the attention of the international community to the importance of a major issue, substantive issue in human rights. And it so happens that the previous one to the current one, occupying this position of Special Rapporteur on the Right to Health, happens to be a psychologist, a psychiatrist from Lithuania. And he issued two reports at the end of his term in 2020. The one you see in front of you here from April 2020 denounced the fact that the mental health system worldwide is dominated by a reductionist biomedical model that uses medicalization to justify coercion. In other words, this is a mental health professional who is saying, I have a mandate in human rights, and I can call it like I see it. And he, Denius Puras, in the same resolution, provided numerous recommendations. I've only cited a couple of them that calls upon the profession, the people who presumably are joining in this webinar, to firmly establish human rights and social justice as core values when promoting mental health interventions, and to modernize medical education and integrate mental health and human rights into medical education and research. He also asked the World Health Organization, and this is a few highlights of the numerous recommendations that Dr. Puras submitted to the United Nations. He called on the WHO to support the development of principles and best practices to implement a rights-based approach to mental health, and to support the development of new holistic list of essential psychosocial and population-based interventions that are informed by evidence and so on. So you can see that in the human rights field, we've come a long way. My final observation is to say that in an attempt, working with the two other people you're going to hear from in a minute, to get a deeper understanding of what is the detailed content of a human rights-based approach to mental health, I took the two existing sets of guidelines, the MI Principles of 1991 and the Convention on the Rights of Persons with Disabilities of 2006, and tried to see whether taken together, we can get a clearer understanding of the full range of human rights that are involved. Obviously, the right to health appears in both. Principle 1.1 of the MI Principles, all persons have the right to the best available mental health care, which shall be part of health and social care systems. And the Convention on the Rights of Persons with Disability did not actually specifically reference mental health, but the entire document is based on that. And that's the only example I'm going to cite because I am out of time, and I'm going to come to my conclusion now, which is, so you can take these two normative frameworks, put them together, and you get the full list of all the rights that are relevant to understanding the connection between human rights and mental health. So for the future, the Special Rapporteur recommended a paradigm shift. He's calling upon the medical and health communities to move from the medical charity model to the social human rights model, to identify policies and practices that address stigma, misconceptions, and discrimination, and to improve psychosocial care, and to ensure that mental health is part of human rights promotion and protection. So those are the principal ideas that have emerged from this collaboration over the last couple of decades between the human rights community and the mental health, or the public health and the mental health community. And that, I hope, forms a framework that will allow you to hear from now two outstanding, genuine professionals in the field of mental health on how this relates to the clinical practice of treating people with mental health. And I'm very grateful to be able to turn the floor over to Lena Verdeli. I think you'll be speaking next, Lena. And thank you very much for your time.
Thank you, Stephen. Let me start by thanking first the panelists for this great invitation, and for you, Stephen, for once again, realizing how clearly and at the same time, thoroughly you give, the framework of the normative framework. So I'm going to focus now, as Stephen said, more on what that means in terms of, our clinical practice, our work, in research, our work with legislation. So mental health, well-being as well as mental ill health is increasingly a public health priority and human rights imperative. One of the reasons is that we see an increase in mental health conditions, especially following the tremendous isolation and cascades of losses of COVID and increasing displacement. Humanity has more than 100 million forcibly displaced persons these days. So these and other social issues have contributed to the rising global disability prevalence. Have an estimated 970 million people. That was in 2019. At this point, the estimation is 1 billion people. 1 billion people with a mental health condition. So 1 out of 8 human beings in the world have, live with a mental health condition. They have developed mental health condition at some point. 1/4 of the global population will experience a mental health condition within their lifetime. And speaking of the burden, mental health conditions account for 32% of years lived with disability, a metric to show this burden of disease, and 13% of disability-adjusted life years, how many years of life the person loses to morbidity and mortality of the mental health conditions. One of the reasons is that these conditions start early in life, and they hit the person during their most productive years, when they prepare their future, the families, they build their vocational future, their education. So, and they last for a long time. Many people with mental health conditions, and this audience knows more than other audiences, experience limited access to basic mental health care, what in our field call treatment gap, the gap between those who need treatment and those who end up getting the treatment, which, by the way, even rich nations like the US is experiencing, especially with our poorer clients. Human rights violations that start, as Stephen mentioned, from lack of consent for very important treatment decisions, and inhumane and degrading treatment and living conditions, especially in the hands of those tasked with protecting them in institutions, right? Exclusion from community life and denial of basic human rights, right to vote, right to marry, to have children. Discrimination in housing, employment, health, life in poverty, the downward spiral is well documented, that actually increases all the social determinants that trigger and worsen their mental health conditions. So this is a dynamic process that spirals them down. And incarceration. And we have a terrible problem in this country with incarcerating our mentally ill human beings. So what Professor Marks mentioned before, the movement is just from equality, which here you see, I like this graph because it shows equality means giving these 3 persons equal, opportunities to see beyond the barriers, to overcome the barriers, where clearly, one of them is favored by that, but the other 2 are not as favored, especially the 3rd person, the child. Equity means give to each one what they need in order to be able, to overcome the barriers. But we can do better than that. And this is what we mean by inclusion and social justice, which is to remove the barriers to begin with. What Professor Marks mentioned before is very important for, the movement from the charity and medical model. So the person used to be with mental health condition to be deranged. Then it became the charity model, where there are victims, we need to really pity them. And then the medical model that said, well, actually, we need to care for them. We have an obligation to care and fix the person. So the problem is the defective person. The CRPD moved the field to a rights-based model, the social model, which tells us that the disabilities, the difficulties that the person with mental health conditions has, actually is, the impairments becomes disability only when it interacts with barriers, the barriers that we saw before in the graph. So the problem is how to really help society remove the barriers, right? And the problem, our task is to help society remove the barriers, right? The prejudice, the segregation, the job prospects, lack of access, no policies for inclusion, right? So access to treatment. And this is what the CRPD did. It really moved the field in a very significant way, unprecedented way. There was, in addition to what Professor Marks mentioned, there is also a very important Lancet Commission. Lancet is a very prestigious journal, global health journal. It was a commission to end stigma and discrimination in mental health. That commission found that basically the single most important strategy is to help integrate persons with lived experience and make sure they are part of, awareness, raising awareness, but not just only through poems and, songs or protests, but who also really describe and produce the agenda are co-implementers, right? So it's raise awareness, but set the agenda, talk about their needs and priorities, and implement the agenda. There was a very recent, in like some weeks ago, a WHO collaboration with the Office of United Nations High Commissioner for Human Rights. They developed new guidance for mental health, human rights, and registration. And this was to bridge the knowledge and practice gap. It was the first comprehensive guidance how to implement human rights and CRPD commitments in mental health within national legal frameworks. So it gave very concrete steps and very concrete, checklists for the governments to, to implement those. So some technical milestones that we need to keep in mind that bridged, the gap with this document are, and you'll have it for your slides, capacity building, the quality rights that Professor Marks mentioned, training, a lot of guidance materials, e-training, guidance on participation, on peer support groups. Everything is available over the online, creating rights-based community services, technical packages on community mental health services. One of the most important developments was the Quality Rights Service Assessment Toolkit, where our colleague Michelle Funk led in a wonderful way that moved the needle in human rights, with basically holding clinics and settings accountable and showing them ways to improve the way they care for persons with disabilities, and policy and law reform. So just to give you some examples of the legislative provisions, equality and non-discrimination. Examples of non-discrimination in insurance, or challenging discrimination in communities, the anti-stigma campaigns that we mentioned, led by and conducted by persons with lived experience. personhood and legal capacity. So making available supported decision-making, safeguarding a person's will and preferences, some important conditions. The next one is perhaps the most contested and controversial area, which is informed consent and eliminating coercive practices. There is a lot of anxiety, a lot of fear around, persons with episodes, psychotic episodes. So very important to support advanced planning, advanced, what we say in clinical work, a relapse drill, who will be doing what when the person relapses, when the person is going into an episode. These advanced guidance from the person when they are more lucid about how they want this to be dealt. The provision of crisis support that de-escalate, regulate the person, assess the person's needs, instead of the tragedies that can happen with just trying to just contain them with regular 911 calls. Access to quality mental health services, support availability, accessibility, acceptability, and quality of mental health services, the Quality Rights Toolkit, which gives us, how much stimulation do people need, guidance on, not neglecting, on reducing and eliminating abuse or exploitation, stimulating the person, giving chance for vocational rehabilitation. Implementing mental health services in the community, not in asylums. Integrating mental health in general health care settings. Integrating peer-run services. We have a big study with veterans where the counseling is done by peers under, with, of course, supported with clinical work. Supporting deinstitutionalization, full and effective participation in public decisions, nothing for us without us, and accountability where it's established monitoring bodies, initiating effective mechanisms for remedies. So going from stigma, which is about attitudes, to discrimination, which is about behaviors, about legislation, and therefore is subjected to accountability. And cross-sectoral reforms, which include promoting community inclusion and multi-sectoral coordination and action. How the Ministry of Health, or the Mental Health Unit, interacts with education, right? For vocational training, for example, for protection, et cetera, labor. And I'll finish just with this this wonderful real-life example in our work in Lebanon, where we were able to develop, the most sustainable program with our WHO intervention that we have been disseminating, because there is a strategy, a human rights-based mental health strategy, where everybody in Lebanon, whether they are displaced people or host community, need to have the right to evidence-based, community-based mental health and psychosocial support, with emphasis on vulnerable persons. And we were able to build a sustainable and scalable intervention that has served Lebanon. The point of departure of this was the influx of Syrian refugees in Lebanon, but it served everybody in Lebanon during all the subsequent, crises, right? The systems of care they made, blasts, economic crisis, the war, et cetera, et cetera. So thank you so much for your attention. And Professor Willis, would you like me to stop sharing for you to, or I can continue because we have.
I'm doing it. It's fine.
I'm sorry?
If you don't mind continuing, there's less disruption.
Absolutely.
Right?
Please go ahead.
Thank you so much, and thank you, everyone. Thank you, Professor Marks and Professor Verdeli, for this opportunity. I'd like to build on a lot of the foundational work shared by my colleagues, obviously, and really looking at how then to integrate mental health, disability, and human rights within policy frameworks, as well as advocacy on both global, national, and local levels. So there are certain directives. So if many of you are joining us today, are saying this is wonderful, this is really good clinical as well as guidelines for international normative frameworks. What do I do with all this information? Where do I take it from where I am? And I think these 4 steps hopefully will conceptualize the principal directives. The first one is to conceptualize mental health and disability from a human rights lens by adopting the human rights or social model. This is needed on all aspects of the community, whether and amongst all stakeholders, in order to combat ableism, stigma, discrimination, and to promote inclusion. And of course, our work has been emphasized in the global health and development agendas, but need to also consider that our work is also within emergency preparedness and response. And from the social and rights perspective or model, adopting foundationally the human rights treaties and conventions that Professor Marks has eloquently outlined for us, as well as the more intricate global standards and instruments such as the Sustainable Development Goals, among other targets and indicators, and international best practice to promote inclusion, protecting the rights and dignities of persons with disabilities and mental health conditions. So how do you then take those international normative frameworks and put them into legislative? And we have now a newly launched guidebook that Dr. Verdeli indicated, but I'll emphasize a bit more on policy and program development, recognizing the validity of the lived experience and promoting in practice a participatory governance. Once you have the legislative and the policy frameworks in place, you are therefore in a position to implement evidence-based practices in equitable and right-based integrated systems of care model. We have been talking about moving beyond health and really looking at the cross-sectoral work that WHO is endorsing, with recovery and inclusive strategies at the core. So it's not just about treating and curing, but really moving towards inclusive and recovery practices, identifying barriers and removing the human rights violations, such as forced admission, seclusion, and restraint, among others that have been mentioned so far today, that are in line with the international normative frameworks. So we're trying to, that imperative or the paradigm shift or that transformational map that we're talking about has to move us from exclusion and human rights violations to inclusion and protection. And for that, we have to identify what are the structural barriers that exist within our institutions, our organizations. And of course, we're talking about attitudinal barriers as well. And that human rights perspective enforces us to ground into appropriate rights-based model. Next segment, please. Looking at the provision of choice for individuals and families and carers, and determining the reasonable accommodations that people need. So in order to access education, in order to access health, in order to access employment and be an active and self-determined member of society, what are the reasonable accommodations that are available and in line with the CRPD? So this is also a legal framework that can be integrated within the inclusive rights-based legislation, policies, and programs, adopting what we call a twin track approach. So what's a twin track approach? It's really looking at disability or mental health specific interventions or initiatives in line with mainstreaming mental health, human rights, and disability across all social development and policy development initiatives that go and the participation, the governance, participatory governance goes beyond tokenistic, informative, and consultative practices, but really getting those with lived experiences along the whole journey of policy formulation as well, down to decision-making, monitoring, and evaluation. Next slide, please.
Sorry.
So I wanted to just talk a little bit about where does this discourse happen? So we've been engaged in shaping the global discourse with World Enabled and impact investment and how governments respond to global challenges of exclusion. Our work, again, follows the twin track approach. So, of course, we're engaged with the COSP, the Convention of State Parties annual meeting at the UN on the Convention on the Rights of Persons with Disabilities, engaging in bilateral meetings, as pictured here with Dr. Victor Pineda at World Enabled, who co-drafted the convention, in addition to really looking at country reports and engaging civil society in that space is really critical. On the left, you have the mainstream model, is really promoting the human rights and inclusion agenda on the global platforms of the World Economic Forum, so engaging in the Global Future Council meetings in order to develop and submit policy briefs, such as those we engaged in T20, which is Think Tank 20, and C20 that shaped the G20 agenda, as well as working with the OECD, among other global multilaterals, etc. So this is one avenue of global engagement. And the next slide is really looking at how such global platform for global advocacy can really trickle down and impact national level advocacy and policy. So here we are talking about the UAE government in Abu Dhabi during the UN Habitats World Urban Forum, engaging them in developing their national strategy for inclusion, that's human rights based. It's an integrated intersectoral work, and we conducted training on how to conduct human rights based inclusive public policy practices. So this was, I think, a really good model. And the next one is working with other governments, such as the Dubai government. Next slide, and showing you a little bit of the outputs. Previous one. Some of the outputs include inclusive education, human rights-based inclusion practices and guidebooks, looking at access in the universal design codes that we launched, ensuring that all children are developing and that there is reducing the treatment gap for children, for child and adolescent mental health and global developmental practices. But this is one of Lena's favorites. And the beautiful thing about working on national policies is when you see the community advocating for themselves. So on the right-hand side here, you will see how retail and other outlets such as aviation industry, etc. We conducted the first conference on rights and inclusion in aviation with IATA, really promoting inclusive travel. And travel taking into consideration neurodiverse populations, shopping centers and movie theaters that are sensitive to those from neurodiverse population communities. And I have to say, the person that's really driving that for me is my daughter, Mia, who's on the autistic spectrum. Next slide, please. And so you have to, that advocacy has to take on multiple partners. Next slide, please, Lena. And so here's a snapshot of some of these global partners. We need to do this as a collective, and we need to do this as a community. And it takes academics, multilaterals, even private industry. And the network such as this one is really driving new partners to come on board as well and bring in a lot of innovation to catalyze this paradigm shift and this transformational agenda. Next slide, please. But I want to pay tribute to the stakeholder engagement. I mean, just look at these faces. This is what it is. This is the reality on the ground, is people committed to pushing the agenda. You will see here the stakeholder engagement with for the child and adolescent mental health government accelerator. So I don't want to just pinpoint just national strategies and policies. Government can put on board accelerators to really push this agenda quite fast. So from these engagements were born the Child and Adolescent Mental Health Accelerator as part of the mental health strategy, but also Dr. Nadia Dabbar, which is much needed. And this is Dr. Stephen, in line with your introductory slide about the Child and Adolescent Mental Health National Strategy for the state of Palestine. I wonder how much work is needed going forward to activate this particular strategy and deliver it on the ground for those who need it desperately. Next slide, please, and finalizing. And I'd like to revert back to Dr. Lena for the Global Mental Health Lab and really encourage everybody to join us into more detailed discussion within our institutes and activities. Over to you, Lena. Thank you.
Thank you. Thank you so much. And we are ready for comments and questions.
Well, thank you all so much for this wonderful presentation. Well, I have some questions here from the audience. I'd like to put together at least two of them to the three of you. And the first one is, why is it that mental health care often appears to be a luxury accessible only to the privileged, despite being a fundamental aspect of human well-being? And I put this together with one of the slides from Dr. Marks. Maybe you, Professor Marks, can start about talking about the agenda for the future. How can we ensure that mental health is part of human rights promotion and protection? So could you please give us some comments?
I'm glad to address that question because I'd like to relate it to what I call the normative expansion. I think I showed at the beginning that mental wasn't even included in the initial references to health and Universal Declaration of Human Rights. Then mental was mentioned, then details were given, then it was more elaborated, then specialized conventions. All this elaboration emerged from a norm that was rudimentary. And the central point here, to answer your question, is that from the point of view of the obligations of states to implement the right to health, the case could reasonably be made that policies and practices that were not attentive to the concerns that all three of us have expressed 10 or 20 years ago would not be subject to criticism from the point of view of human rights. What we call the normative expansion means that today, the correct interpretation of the content of the right to health includes all of these dimensions of the right to mental health. And that's why the special rapporteur referred to it as the right to mental health, so that it is no longer possible for a government to report on what it's done to realize the right to health and say, yeah, mental health, okay, we'll try to get to that. We don't have the resources now, but sure, we'll work on it later. No, things have changed. Now these are regarded as obligations today. If you fail to meet those obligations, you may legitimately be held as a violator of your obligations under the right to health. I don't know if that answers the question the way you conceived it, but that is kind of an evolution that has occurred. It is no longer optional, it is required.
Right, thank you. Thank you so much. Dr. Verdeli, Dr. Willis, please feel free to comment on that as well.
You know, this has been a huge question in my field for years. We knew since the 90s, that adversities increase mental ill health, right? So this notion of the romantic, the native, that all these things happen, they stay well. It's, of course, it doesn't exist. People are very resilient, but people suffer tremendously as well. There was another, hesitation to feel like, okay, is it a Western thing, right? And in our ethnographic work, when we, approach and understood from our local experts, the local idioms of distress and how they understood it and what they're doing, we realized that there are some, common denominators there where when people lose significant others, when they go, under these adversities in some very poor areas, under extreme adversities, they, their bodies and minds suffer. So they have different ways of expressing it, but there is a common denominator of pain and suffering that, you know, in our work in Uganda, in Nepal, you know, we saw the local idioms, people, how they talk about it and how they describe the toll it took on human lives and the burdens on the families and on the society. So it's not like a Western invention. The other thing is that, you know, it can be treated. So I had the amazing opportunity to work with, you know, colleagues and participate, you know, in the early clinical trials, actually, of psychotherapy and packages adapted for local relevance to address local idioms of distress, showing that actually, according to local, you know, people's assessment, they were helpful in increasing the symptoms and improving their functioning. So that, I think, was very helpful, you know, and then, as you know, Stephen said, there was this constant interaction with the normative frameworks, because all these things, without changing the frames that would lead to accountability, right? It's not just, you know, it's our obligation, right? From the sick person became a person with rights. It's our obligation. It's not charity. It's not optional. So that was very important.
If I may
Right.
jump in, Alison, I'm
Please.
conscious of time, so I think my response will be twofold. One, bottom up, other top down, I feel. The bottom up is my favorite because it reminds me of my daughter, Mia. It's about self-advocacy. Now, how did she grow up to know how to advocate for herself? Huh? So it's through about awareness. It's about anti-stigmatization. So she's in a position where she shows her Autism Society card that has her needs. If she becomes nonverbal, if she's having it, she knows how to advocate for herself, to a point where I'm embarrassed sometimes when we are at the airport and, you know, things are unraveling and she pulls out her ID, she pulls out her badge and says, you have to provide my accommodations. So this is where we want the next generation to go. But that takes work. It takes a collective, the community, to come together and inform people of their rights and provide them a safe space to advocate for their rights. You know, she had to move to another continent to make that happen. We as a whole family had to move to another continent to make that happen. The other one, the top down, you know, mental health service and disability used to be almost exclusively specialized care by special trained people. The word special was everywhere. And the word special had a tag on it, and that was a $sign or £, or whatever you want to call it. It was monetarily determined. Okay, now we know actually a lot of the outreach and a lot of the treatment, and a lot of the intervention is done by community health workers. It's done peer-to-peer. It's done non-special, if you will, from a professional standpoint. So it's about the stepped care model. It's about the provision of community-based care. It's about training our teachers and employers, etc., to recognize signs of distress and know how to support individuals within your community, whether family or beyond. And really moving upstream. Can we really talk about mental health prevention and promotion before we really move into the areas where specialty care is required and you're more reactive? And then that's costly. And then that's exclusionary, because people who can't afford that care won't be able to access it. Thank you.
Perfect. Well, we have a lot of questions and we have no time, but I'd like to ask you if you want each one of you to leave a last message for all of us, please. Could you start, Dr. Verdeli?
Well, to thank everybody for, you know, invitations like this, and for an audience like this. I see all these wonderful of these great questions. I would like to make myself available. I'll leave my email to you so that if people have specific questions, they can please, let's continue this dialogue.
Mhm. Thank you. Thank you so much. Dr. Willis?
I'll do like a coin term, and it's really for the sake of humanity, for the sake of us all, and for our children's future. I know it sounds corny, but that's why I'm here. That's why I do this. And yeah, for the sake of our humanity, let's do this.
Yeah. Dr. Marks, please.
I couldn't agree more. It is for the sake of our children, for your daughter, for the children of Palestine, for the children of Israel, for the children of all places where inadequate healthcare is provided and where mental health is not treated as an integral part of the required level of healthcare for a state to be considered as in compliance with its obligations under the right to health. My final point, though, is to say that one of the things that has come out in the presentations made by my colleagues is that there are institutional developments going on. There are activities going on. There are national policies that are being developed. Your Gulf state stories were eye-openers for me. I was unaware of the existence of those. So I would like to think that the people attending this conference, or this webinar, could exchange information about ways in which we can engage so that we can help these projects move further along. But the fundamental reason is we care for the very important reason that those people who are not getting adequate care, whose right to health and right to mental health are not being attended to, are our responsibility, everybody's responsibility. And we need to act at the professional and civil society levels to change this.
Very good, very good. Well, we're very glad that you were here with us, and we're very thankful for your time. Thank you very much. We encourage you to access our website, humanrightspsychology.org, so everybody will be able to watch this webinar and other webinars as well. Marlena, please.
Thank you very much. Thank you to Alison for moderating this, to navigating through the many questions that arose during your presentations. Thank you to all three of you. I would just like to say something. You all three of you wrote a chapter. I don't know if you can see in this book. So this was this book appeared 3 years ago. At the same time, another book, Human Rights, what's the title? Human Rights Education for Psychologists, appeared as well. Obviously, what I could read in your comments and the questions is that there is a huge need among us, psychologists, students of psychology, to learn more about human rights and how to translate the procedures, the laws into concrete everyday work that we do, so that people who work in, our colleagues who work in schools, in kindergartens, in organizations can implement, can improve mental health and human rights for the people they work with. That is very important, and we are in a way in a pioneering field, and we need to learn about those things. So the webinars have the goal to raise our curiosity and to learn about the things that some people really have been doing for a longer time. So yes, please give your suggestions in the feedback. Mary, you can show the last slide so that you remind me what to say about the feedback. We will send you evaluation forms in a couple of days, and you can suggest some topics there. You can also suggest some other forms of learning or teaching, so we can see what to organize in the future. You will also receive the certificate of attendance. Some of you asked, and also some of you asked about this webinar being recorded and available later. That is going to we will do that. So you will receive also the information about that. You will be able to find the recorded version on the website of Global Network of Psychologists for Human Rights. So you can watch it again and learn some things that you probably missed during its live version. And there is something I would like to tell you about the next webinar. It is scheduled for January next year. It's actually easy to remember because it's 24th of January in 24. So at 4 p.m., but that's just for the Central European time. Eva Thompson and Polly Hagenars will be speaking about human rights-based and oriented psychology and its foundations. So please join us, register, and let's meet again at the very beginning of the next year. Thank you all for attending.
Thank you. Much
Thank you.
appreciated.